Okay, let's go into surgical interventions for female reproductive problems. Share my screen. Here we go. So for the hysterectomy, we will be needing to do a few things. For post-operative care, in addition to the standard pre-op, post-op things that we have talked about several different times throughout the course of the term, and I keep referring you back to week 1 for pre and post-op care. We just got done surgically intervening in a person's abdomen. So abdominal distension is going to be a hugely common side effect of that intervention. There will be food and fluid restrictions because of that abdominal distension, and ambulation is incredibly important. Ambulation helps the body move that extra fluid, that extra inflammation fluid out of the peritoneal cavity and out of that area and in through the lymph system and then out through the kidneys and however else it needs to go. The importance of ambulation, our ambulation is also important because it is a key factor in DVT prophylaxis. DVT is deep vein thrombosis. So what can happen with people who have hysterectomy is they become less active, probably because of the abdominal distension and the pain that's associated with having that surgery. So that increases the likelihood of them developing blood clots in their deep veins, and then having emboli, which are pieces of that deep vein clots, that deep vein thrombus, break off, and the emboli can travel wherever, causing stroke, heart attack, pulmonary embolism, and a variety of other circulation problems. So applying intermittent pneumatic compression devices, using frequent position changes, avoiding high Fowler's position, and avoiding pressure under the knees and encouraging leg exercises are all really good methods of getting DVT prophylaxis happening, as well as frequent ambulations. We also need to do some education about when you have a hysterectomy, you don't have a uterus anymore, so you won't have menstruation. However, if you've been able to keep your ovaries after surgery, so if you just had a hysterectomy without an oophorectomy, you will have what's called dry period. So you'll still have the hormonal cycle going on, but you won't have the period shedding of the menses because there's nothing to gather the endometrial tissue. There are going to be some activity restrictions, nothing heavier than a gallon of milk for at least 3 to 4 weeks, avoiding intercourse for at least 4 to 6 weeks. And if they use a vaginal approach, I'll talk about different approaches to hysterectomies here in the next slide, but if they use a vaginal approach, there may not be several sensation returning to the client for several months. And then there are a lot of physical restrictions until healing is complete. We did just do an abdominal surgery, so anything that requires bending, lifting, moving of heavy items is going to be verboten. It's going to be great. So hysterectomies, there's a couple different ways that, a couple different things that can happen with a hysterectomy. So we can either have the fallopian tube and the ovary floating there. We can attach them. We can have a vaginal suture line, and then indeed that is a total hysterectomy. So just some language that's associated with the pictures here. In A, that is a cross section of a subtotal hysterectomy. There still is a cervical stump, fallopian tubes, and the ovaries remain. In B, that is a total hysterectomy, but the fallopian tubes and the ovaries remain, but no cervix. In C, that is a vaginal hysterectomy. So there is the fallopian tubes and the ovaries remain. This particular client had their surgery happen, their hysterectomy happened using the vagina as the main approach. rather than having, let's see here, there are times where the doctor or the surgeon, depending upon what their preference is, they can either use an approach this way and go in through the lower abdominal wall, or they can remove the vagina or the uterus through the vagina. So that's the two differences between the two approaches. And then B is a total hysterectomy. So not only was the uterus removed, but in addition, there was a salpingectomy and an oophorectomy. A salpingectomy is the fallopian tubes, and oophorectomy is the removal of the ovaries. So there are no uterus, fallopian tubes, or ovaries in the postoperatively. So for a salpingectomy and an oophorectomy, the post-op care is similar to abdominal surgery patients. If there's a large cyst removed, they may still have that abdominal distension that we talked about with a hysterectomy. They may have an abdominal binder to be able to keep that surgical site closed. And people who do not have their ovaries anymore may have, they have like this instantaneous loss of their estrogen and their progesterone. So they may have a really bad menopause because like legit 1 minute they had that hormone source in their body and then they didn't. For a vulvectomy, there is, we need to consider the significance of the extent of the vulvectomy and provide emotional support. Because this is in the perianal area, there is going to be bowel and bladder care that's going to be associated with this. We are not going to be wanting them to have large, hard stools by any means. So they're going to be using stool softeners, a low residual diet, as well as indwelling catheters. Healing may take a long time. So there's going to be some anticoagulant therapy that goes along with this, some analgesics that go along with this, and then some self-care, as well as when they need to call the healthcare provider and see if they need to be seen in the clinic, in urgent care, or in emergency room, depending upon how severe things are going, and any sort of like home care nursing that may need to happen. They may be debilitated enough, they may need some home health visits rather than just simply being discharged. This area, this perianal area, this vulvar cancer can also affect sexual function just because of the penetration that's allowed or that's surrounding sex in that area, and that can be really painful, and they need to be able to have open conversations about how sex looks, how it feels, how it operates after having this type of surgery. There may be, if we have a cancer, this is a really, really extreme intervention. So what this is it's called pelvic exenteration. And pelvic exenteration, it's a radical surgery when other forms of therapy can't control the spread of cancer, and the cancer is limited to the pelvic area. In this particular surgery, as you can see, the uterus, the ovaries, the fallopian tubes, and the vagina have all been removed, as well as the bladder, the urethra, pelvic lymph nodes, and there has been, the client now has even maybe part of their rectum removed as well. So they have ileoconduit, and they have a colostomy or an ostomy side as well. So these people will need lots of different education on how to manage their new urinary exit strategy, which is right here, and their new colon exit strategy, which is here, which is not where they're used to managing these sorts of things. So when it comes to caring for these clients, there is a lot of post-op care that is similar, and some of it's a little different. So a lot of it's similar to other abdominal surgeries. There's going to be distension. We're going to be doing analgesia. They need to know signs and symptoms of infection and things that they need to come in for. However, these people are also going to have a lot of physical, emotional, and social adjustments. They no longer sit down to go to the bathroom. So they have urinary and or fecal diversions, which is what that colostomy is, and that's what the ileoconduit is. They may get a reconstructed vagina. They may not, depending upon everything that's going on with their case. There is a possibility of lymphedema, which is a large amount of lymph that collects rather than gets moved through the system, simply because their lymph nodes may be removed as part of that surgery as well. Because there is no ovaries, there is no more opportunity for that hormonal balance, and it will be a sudden onset of menopause as well. There is a large amount of rehabilitative process that goes along with these people, both physically and emotionally. That process needs to keep pace with the patient's acceptance of the situation. The recovery period can be really long. It's a big surgery. We're going to be gently encouraging them to regain their independence. They may have some huge impacts to their self-esteem because of all of the different surgeries. We need to allow them to express those feelings, and we need to use our really good assessment skills to determine if follow-up monitoring is needed. Because the cancer was so severe, this person may also be getting radiation therapy, or a person with certain types of female reproductive organ cancers may be getting radiation therapy anyway, like a uterine cancer or ovarian cancer may be getting radiation. But we're going to be teaching in these patients how to urinate to minimize radiation exposure. We're going to teach them to urinate before going into radiation exposure during the treatment. Because if that bladder is empty, it's smaller and it's out of the way. We don't want a big, nice, full bladder getting in the way of the radiation beam. There are also going to be side effects of radiation therapy, including enteritis and cystitis. So enteritis is an inflammation of the colon. Cystitis is an inflammation of the bladder. So it's going to hurt to poop. It's going to hurt to pee. There are going to be increases in frequency of both of those. And if we can work to not only minimize their personal exposure to radiation, but our own personal exposure to radiation, that is a definite bonus. And then when it comes to evaluation of any of the female reproductive organ problems that I've just been talking about, patient with cancer of the reproductive system will actively take part in treatment decisions. Teach us back about pain and symptom management, recognize and report symptoms appropriately, be able to maintain their preferred lifestyle, and actively practice cancer detection strategies. So this is the end of my talk about female reproductive organ problems. I will see you shortly for male reproductive organ problems.